Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School on the Duluth campus. And I'm your host for this last program of the season on eye problems. Please call in your questions on the diagnosis and treatment of eye problems such as glaucoma, cataracts, dry eyes, conjunctivitis, or other questions that you may have, and we will do our best to address them. Our panelists this evening are Dr. Charlie Ahrens, an ophthalmologist with St. Luke's Miller Creek Medical Clinic, Dr. Lisa Graham, an ophthalmologist with Ralph Eye Care Specialists in Hermantown, and Dr. Joseph Morehouse, an ophthalmologist with Essentia Health. Our students answering the phones tonight are Jackie Blomker, Melrose, Minnesota, James Holmquist of Alexandria, Minnesota, and Elena Kabanuk of Little Falls, Minnesota. As always, the success of this program is dependent on you, the viewer. Please note the telephone numbers for your questions at the bottom of the screen. And now on to tonight's program. I think tonight that we'd like to start off with just a little bit of eye anatomy. We do have a model here, and Dr. Ahrens was kind enough to bring it, so we'll let Dr. Ahrens give us a little bit of an anatomy lesson to be critiqued by his colleague.
Well, we'll start. This is just real basic eye anatomy. We've got a cross section of the eye here, and light will enter in from the front of the eye through the cornea, which is kind of like the clear shield that covers the front part of the eye. Sitting behind that is the colored part of the eye, or the iris, which I'll turn just a little bit, and you can see it right there. And there's a small little opening or an aperture, like if you're talking about a camera, that light will travel through. Sitting behind that is the lens of the eye, kind of sitting right here, which is, as we age, that will get more and more opacified, which is what a cataract is. Sitting in the back of the eye, you've got the back wall of the eye, which is lined by the retina, which basically will absorb the light and send a neurologic signal to the optic nerve, which is located at the very back of the eye, and the optic nerve travels back into the brain, which carries the neurologic signal, which our brain then interprets for our vision. We've got multiple intraocular muscles, which are on the outside part of the eye, which help us move the eye back and forth and turn it as we need to see different things, obviously, during the day.
So Dr. Graham, as we get older, what kind of changes take place in the eye?
Wow, lots of changes take place in the eye. The one that most people are familiar with, I think, is cataracts. So the lens, as Dr. Ahrens described, sits in the front of the eye behind the iris and the pupil, and it is sort of gelatinous when you're young, very flexible and clear, but as you get older, it starts to get more dense, and then it gets cloudy. When it's cloudy, we call it a cataract, and when it's just getting dense, it makes us need these things, reading glasses.
So that's at about age 40, 50?
43, 45, you start to
time?
do this a little bit, and then you start to need something to help you out.
Dr. Morehouse, talk to us a little bit about cataracts and what you can do about them, and I think we can probably enter into a discussion about surgery and so on.
Well, cataracts, as Dr. Graham mentioned, the cataract is when the lens is cloudy. When it gets cloudy enough to interfere with our daily activities, then we think about how do we treat them. And the only treatment really for cataracts is to remove them surgically, which means basically going inside the eye, removing the cloudy lens, and then replacing it, the focusing power that lens gives you, with a man-made clear plastic lens.
So in the old days, it seemed like that happened in older people than where you're doing it today, that you're doing it in younger people. Is there a reason for that?
I think that probably because it's safer than it used to be in the old days. I think we used to use a much larger incision, and it was if you will, a cruder surgery. And I think the outcomes are so much better today, and the recovery is so much shorter and briefer, and the complications are, it's not like you can't have a complication, but they're less likely to happen today. And so I think our threshold for determining when a cataract is ready to go has changed.
I think to piggyback on Joe's point too is that we also have a lot of studies now that show that removing the cataracts, once they're visually significant and medically necessary, also decreases our risk for other things in life, things like accidents, falls, and overall better quality of life. And so we're realizing, or over time we've realized, that the earlier we do that, once they're medically necessary, patients can have a much better quality of life once we remove the cataracts as well.
I understand, Dr. Graham, it's a very small incision, and
Yes, it is.
it's
2 small incisions.
2 small incisions.
Most nowadays don't even require any stitches to close. The healing time, most people can see the day of surgery, although it's sort of blurry, and see quite well the day after surgery. So the recovery time has become much quicker, and the return to full activity much quicker.
And generally you do one at a time?
Try to do 1 at a time in most people.
I think it's a great operation, and it's made a lot of difference, because I remember the Coke glasses and everything else that, Coke bottom glasses that people used to wear when they had their cataracts removed. I think my grandfather. And then it was hard for him to keep his Model A on the road, so there was things that went along with that. Dr. Ahrens, talk to us a little bit about floaters.
Floaters, I'm pretty sure every time we come on this, we get questions about floaters, and this is something that will generally happen with age. In the back of the eye, where we kind of show there's a large space, is filled with the vitreous, and it's a gel-like substance, and as the candles on the birthday cake increase, that gel will start to liquefy. And when it liquefies, it can kind of move around a little bit, and when that does that, it can actually separate off of its attachments on the retina. When it does that, instead of looking through like a clear stretch out sheet of cellophane, it pulls off and it can crinkle up, and that's what we see as our floaters. It's very common. What we have to worry about is that when that happens, it can actually tear the retina, and if it tears the retina, that fluid can tuck behind the retina, causing a detachment. So if we see those patients that have new symptoms of new floaters, new flashing lights, dark shadows in the vision, things like that, we want to get a good dilated exam to look and make sure that we don't have any tears or detachments that we need to fix.
This person is talking about a black speck that follows eye movement outside of the vision, the central vision, I would guess. And he notes that it looks a little bit like a fan, so that's kind of...
It could certainly be a floater. You'd also want to make sure that we're not talking about other things that might be inherent to the retina, things like artery or vein occlusions, or there's a multitude of other retinal issues that could have those symptoms. And so in that situation, I'd want to get a good dilated exam to look and see what's going on.
I would add, I see people, like, when people complain of that as a sudden onset, if their vision is otherwise fine, they should get in to see the eye doctor soon, but it's not an emergency. But if there's a lot of floaters, or the vision's declining, or as Dr. Ahrens said, they're having flashing lights, then it should be a little more urgent within a day.
And with a floater, can they see their optometrist, or start with an optometrist and they refer and all? Very good. Tergium, Dr. Morehouse. Treatment and outlook for someone that has one.
So a pterygium, defined is a growth of the conjunctiva onto the surface of the cornea, and many times, probably most pterygia are not treated, but when they become symptomatic, which is to say they might affect the vision, or be causing astigmatism, or be causing discomfort, then generally, well, if it's just discomfort, you can try to treat them with lubricating drops, that sort of thing, maybe some mild steroids, but the definitive treatment of pterygium is to surgically excise it.
What seems to be the cause of those? Is it genetic?
It's
or
solar damage.
Solar
in general.
damage?
They're much more common near the equator. In the Caribbean, you'll see people in the tropics with very advanced pterygia.
Dr. Graham, macular degeneration. Let's go to that just a little bit. You want to tell us what it is?
Well, it's another one of those things that we get as we get older. The macula is the central area of the retina that is responsible for your fine central vision. Some folks develop little deposits in the retina and then thinning of the retina, and we'll call it macular degeneration. It's pretty common. About 20–25% of people over the age of 50 develop some form of macular degeneration. Not everybody has severe loss of vision, thankfully. There are two types, the dry kind and the wet kind. The dry kind just refers to the thinning of the retina and sometimes severe vision loss, although sometimes mild vision loss. But what people fear the most is the wet kind, and that's when new blood vessels can sprout up in the retina or leaky spots develop in the retina, and you can get bleeding and scarring in the retina and sudden loss of vision. That's a little more difficult to recover from. But in recent years, we've developed medications. You can have injections to slow down the wet kind of macular degeneration. So, and there's a lot of research going on in the area of macular degeneration therapy.
Are there things that an individual can do to keep from getting it?
There is no cure.
You don't have to carry this alone. These two guys can jump in too.
There are genetic variables at play, so some people just are not blessed with good genes. Nutrition and environmental factors, so just having good health in general, so taking care of your blood pressure and exercising and eating right. So the typical diet that we recommend is lots of vegetables, dark green leafy stuff. Bright orange, yellow, and red vegetables have the antioxidants that are really good for the retina and help the metabolism of the retina.
I like to tell people that the risk factors for macular degeneration parallel those for heart disease. And so the ones that you can affect are your body mass index, your cholesterol, your blood pressure, and whether you smoke or not. The ones you can't affect, age and family history.
There is a question, I think you answered it, but the question is, will this person go blind with macular degeneration? And I guess my answer has always been you lose center vision.
Exactly, and that's sometimes very comforting for people who have macular degeneration, that you're never going to really lose your side vision from macular degeneration. And people can get around really well with peripheral vision, even if they don't have any fine central vision.
Corneal transplants, do you do these?
No, Dr. Baruch is not here.
No, I don't think any of us do those.
Do they work?
Do them.
I guess that's,
Yes.
that's the question.
Yes, we know a little bit about them.
And there's been a lot of advances even over the last 10 to 15 years in how we do the corneal transplant, what portions of the cornea that are transplanted versus, you know, the decision to make a full thickness corneal transplant versus the most inner layer becomes transplanted, and so depending on the corneal disease will determine which type of surgery that person would need.
Couple of eyelash questions. This person has a son whose eyelashes are growing straight down. And it's like he's looking through a screen. Is there some way of fixing that or curing that?
There is.
It kind of depends on the age that we're talking about. I mean, if it's an infant, sometimes those kind of develop away. But there sometimes are surgical procedures that can be done if it's an extreme case.
And the most common surgery is probably one that I think all three of us do, which is a blepharoplasty, where we remove basically the excess skin on the upper eyelid, and sometimes just doing that will turn the lashes out enough, but it also depends on the patient's anatomy, like Dr. Morehouse said, you know, what the age of the patient is, and if there's any other underlying issues going on.
And that you bring up blepharoplasty, this is a procedure that's helpful when you are getting to the point where you can't see so well, or where the lids are coming down.
Correct.
And
Yeah.
Yes.
And are there criteria that you have to meet to do that?
Yes. Everybody wants to know, will insurance cover my eyelid surgery? And if it's visually significant, if the excess skin is blocking your vision to a certain degree, insurance will cover it, and it'll be considered a functional blepharoplasty. If it's not, it might be considered cosmetic and not covered by insurance.
Dr. Morehouse, what can you do about a sty? It's usually in the lower eyelid, or this is where this person's is.
So typically styes are inflamed or blocked oil glands of the eyelid. We have several of what we call meibomian glands in our eyelids, and usually the first treatment for a sty is to use hot compresses on there to try and draw it out, and many times they will resolve on their own. In some cases, they'll kind of evolve into what's called a chalazion, which is a more chronic bump on the eyelid that sometimes ends up needing to be drained.
Dry eyes. Eventually, I knew the question would come. Dr. Graham, do you want to jump on that one?
Oh boy, could spend all night on this one. Well, we are.
And part of the question is, are there new treatments?
Okay, are there new treatments? Yes and no. Dry eyes are pretty ubiquitous in northern Minnesota in the winter. So we lose a bit of tear production as we get older. The oil and mucus production on the eye is important as well. If you're in dry winter months where there's no humidity, then your tears will evaporate more quickly. So those are all factors that you can work on. You want to do warm compresses to improve the oil flow. You want to take artificial tears to lubricate your eyes. Nutrition, again, can be a factor. You can eat healthy oils that can improve your oil production in your eyelids and on the surface of your eye. That can help. There are prescription eye drops that can help with the inflammatory effects of dry eye. And then there's some sort of pulsed light or heat treatments that can improve the oil flow and help with dry eyes in that way. So there's a whole plethora of dry eye treatments, and it's pretty complex, actually.
One thing that I tell everybody that walks in my door: drink enough water,
Drink enough.
stay hydrated. It's one of the very simple things that we can do, easy, cheap to do, and I've found that it helps a great deal with dry eye treatment.
We kind of forget that we live in the great American desert in the northern latitudes. And
Just setting up a humidifier can help
Yep.
tremendously.
how long after eye surgery, so we kind of talked about cataracts, how much time needs to go between the first cataract and the second cataract?
I routinely do about 2 weeks as long as everything is going well. Sometimes following cataract surgery, we might wait 2 to 4 weeks before we'll prescribe glasses just to make sure everything's healed okay. But for the large majority of my patients, by 2 weeks, things are healed up enough, things are stable enough to where if they need glasses, we can give them glasses or send them on their way after the surgery.
What kind of complications come from having cataract surgery? Joel?
Well, there's, as with anything, Murphy's Law can apply with cataract surgery. Probably we could start with the most common complication, which is we actually leave the lens of the eye actually has a shrink wrap-like coating that surrounds it. We peel off the front part in the cataract surgery and then take out the inside of the lens, but we actually leave the back part of that shrink wrap, which forms the pouch into which we put your new lens. And in many cases, that shrink wrap will turn into more like wax paper and make the vision kind of go down. And there's a treatment for that called a YAG laser that we will often do. So probably 20% of people get that. Beyond that, there's the most feared complications are infection inside the eye. There is also retinal detachment. It's rare in this day and age of small incision cataract surgery, but you still can get a bleeding complication underneath the retina. You can lose all your sight from cataract surgery. Fortunately, that's extraordinarily rare these days, but it's not a zero rate of occurrence. And I could sit here probably for the rest of the show and keep going with other complications that none of which are common.
Very, very seldom. Usually the YAG laser need is the only one that I remember, actually. And that doesn't happen very often.
It's probably 20%.
Yeah.
Dr. Ahrens, what type of sedation do you use during cataract surgery?
Very, very little. Most patients nowadays with cataract surgery, the majority of the time we just use topical anesthesia to numb the eye. We use a little bit of medicine inside the eye to numb the tissues on the inside of the eye, and patients usually only need a very small amount of sedative, if any at all. I actually have a lot of patients who choose not to do any sedation, and as long as they can tolerate the procedure well, we don't need any. But we have it there available in case if patients are having a little bit more anxiety or want that availability.
Sjogren's disease causes pretty dry eyes. Anything special or different that you do for Sjogren's beyond the dry eye treatment?
Just aggressively treat the dry.
Yeah, you can aggressively treat the dry eyes, and Dr. Graham went over quite a bit of our more baseline treatment, and if those aren't working, then we can ramp up the treatment into like punctal plugs, mild steroids, and things like that. There are some more long-term oral medicines that we can try as well. A lot of times if patients have Sjogren's, they're having other systemic symptoms, and a lot of times if they have a rheumatologist or primary care doctor, that avenue of treatment will help their underlying dry eyes as well.
Dr. Graham, someone's asking, what's the difference between an optometrist and an ophthalmologist? It's a good question.
That is a good question. An optometrist has a college degree and then an optometry degree. They are very qualified to see like routine patients, prescribe glasses and contacts, and do a healthy eye checkup and diagnose diseases. They treat a lot of diseases too, medically. So when you get into the realm of more complex medical diseases and surgical diseases, that's where an ophthalmologist has a little more training. So an ophthalmologist goes to college and then medical school, and then they do their training in ophthalmology. So we do a internship and a residency following medical school, just like other physicians.
61-year-old in 1997 had a bad fall and detached a retina, which healed on its own. Now he sees floaters. I assume it's a he. And no, it's a she, and makes her nauseous. Also poked a branch in the other eye as well. Are there any treatments that this person should consider?
I'm not sure I'm familiar with floaters causing nausea, but there are some treatments for floaters. If floaters are bothersome and they've been there for 6 months or more, there's a laser treatment that can be done. And there's also, you can actually have your vitreous kind of surgically removed to treat floaters. Most floaters we don't treat. Most of them go away on their own or become much less bothersome. And I'm not sure I answered the full question there, but at least the floater part.
Diabetic retinopathy. What is the basic treatment? One of you want to take that on?
It depends on how much retinopathy. So when we talk about diabetes, the long-term elevation of sugars in the blood will eventually cause the very small blood vessels, particularly in the retina and in other parts of the body, to kind of shut down and leak and bleed. And so if it's very mild, we basically say, make sure that we get the diabetes under control. If it gets more and more, you can have leaking into the retina, you can have bleeding, you can have new blood vessels growing, and all of those, depending on what's going on, can have different treatments. For instance, if you just have swelling in the retina, a lot of times the intravitreal injections, which are very similar to the ones we use for macular degeneration, can be helpful. Sometimes we need to use laser in the back of the eye as well, and it all just kind of depends on how bad that retinopathy is.
Is there an eye connection to myasthenia gravis?
There is.
And would a consult with an eye doc help?
It could, yes. Folks who have myasthenia gravis have their immune system generates antibodies that interfere with the transmission of a nerve impulse to a muscle, and it can affect the movement of the eyes. It can affect the eyelid and the blink and the height of the eyelid, so they can get a droopy eyelid or double vision if their eyes aren't moving properly. And sometimes ophthalmologists are actually the first ones to diagnose the myasthenia gravis because of that.
Pseudoexfoliation syndrome. One of you have any comments on that?
Pseudoexfoliation syndrome.
The person wants to know if they would talk about it. So,
is very common up here. It's one of the groups that is commonly affected by pseudoexfoliation is people of Northern European ancestry. So that's pretty much Minnesotans and Wisconsinites. So pseudoexfoliation by itself is not necessarily harmful, but it's a risk factor for glaucoma, and it's also a risk factor for cataract surgery being more complicated than it might otherwise be. So usually if I see someone with pseudoexfoliation and they don't have glaucoma, then I'll probably want to see them once a year and just watch their pressures in their optic nerves. Having said that about cataract surgery, the vast majority of people that go through cataract surgery that have pseudoexfoliation end up doing great. But there is just a little bit higher risk of complications.
what is a drusen, and are there treatments, prognosis?
Drusen are the way I describe them to patients, they look like little white spots on the back of the retina, and they're basically like a deposition of the waste products of the retina cells. And if you have just a little bit of mild drusen, they're not really problematic at all. And I think of it on a spectrum where if you have just a little bit of mild drusen, that's normal aging changes. If it's really, really bad and we see big drusen, large areas with atrophy, then we're starting to get into the realm of macular degeneration. But if we just have a little bit, then usually not very problematic.
Right eye is stiff and doesn't want to work with the left. What could cause this?
I guess it's my turn. A lot of things. The right eye is stiff. You could have something like we talked about, myasthenia gravis. Thyroid disease can cause that. Some
Muscle
people,
weakness.
yeah, just a muscle weakness. The eyes tend not to work together. A neurologic problem could do that, such as a stroke.
I need to close. Thank you.
Oh,
I want to thank our panelists, Dr. Charlie Ahrens, Dr. Lisa Graham, and Dr. Joe Morehouse, and our medical students tonight, Jackie Blomker, James Holmquist, and Elena Kabanek. All Doctors on Call programs are available for you to watch online at wdse.org. Thank you for your faithful viewership and great questions this evening. Have a good evening, good night, and a great off season for us. Thank you.